I'm going to present to you today, and this is the first presentation of these results of findings from a 4-year study that we just completed, where we looked at fibrosis and lymphedema in head and neck cancer patients. And I'll tell you about the study as we go through. We were fortunate enough to receive a large federal grant to fund this work. And this is an aerial photo at Vanderbilt University Medical Center. We're a medium-sized academic institution, but we have 5 hospitals, a medical school, and a nursing school. So we took up a lot of real estate for the healthcare side of the university. Let me give you a quick background about head and neck cancer. In the United States, there are 50,000 new cases this year. And we have about 500,000 people who survived head and neck cancer. This is not a highly survivable cancer, unfortunately, because those people are diagnosed at stage 3 or 4. And when I was a young nurse 10 years ago, we had patients with head and neck cancer who were mostly smokers and drinkers and old men. And that's what my patient population looked like. However, the human papillomavirus is changing the complexity of this disease. The most rapidly growing cause of head and neck cancer is HPV virus, the same strains that cause cervical cancer. And it is infecting younger patients, and many more women than ever before are developing head and neck cancer. The good news is that if you have head and neck cancer that's HPV driven, you are much more likely to survive for many decades after the disease, because these tumors are much more responsive to the standard chemo and radiation therapies that are given for this cancer. So we have a lot of younger people who will live for many years with the side effects, perhaps, of having had head and neck cancer. Prevalence and incidence rates of lymphedema and fibrosis in this population were unknown. This is actually one of the most understudied cancer populations in the world. So we did the 4-year study to try to address the gap, particularly around fibrosis and lymphedema. And I'm not going to go over this diagram and bore you to death, but I want to point out one thing. We hypothesized when we wrote this grant that subsequent to surgery and chemoradiation, people would develop lymphedema and fibrosis. That's the only thing I want you to remember off that slide. Subsequent to treatment is what we thought we would see. So we had 3 aims to the study, but I'm only going to present one today. And that was a simple aim to determine the prevalence and nature of late effect lymphedema and fibrosis in these patients. Late effect meaning 3 months or more post-completion of their treatment. We had 3 hypotheses. We thought optimistically that about a minimum of 20% of the patients would experience fibrosis with lymphedema, and that we would be able to differentiate patterns of the development, meaning that we would see some very distinct patterns with certain types of surgical procedures, radiation, and things, where we could target those patients on the front end if we got some of the data from the study. And we also wanted to look at symptoms that these patients had related to fibrosis and lymphedema. In other words, if they had swelling or the contractures and fibrosis happened in their face or neck, what did this do to them? Okay? So this was a longitudinal prospective study. What does that mean? It means we enrolled people before they began their radiation and chemotherapy treatment for head and neck cancer. A few had had surgery beforehand, most had not. And then we followed them for 12 time points, 18 months post-treatment for their lymphedema. So we followed them for almost 2 years total, from pre-treatment to 18 months post. I'm going to present just 3 of the measurement methods that we use. We've actually developed several new protocols to diagnose and assess lymphedema and fibrosis in this population. But that's another day and another presentation. So on all of these patients at every visit, We conducted an extensive physical examination to determine if they had external swelling in their face, head, or neck at any time point that we saw them. The CTCA criteria are the common toxicity criteria for adverse events that we are required in the United States to monitor for in every drug trial that's done in the U.S. Lymphedema is one of these possible adverse events. So these are the criteria we use to develop statistics about lymphedema as a result of drug therapy, but it's also what we use to standardize the physical examination, okay? We also scoped these patients every time we saw them. We put a flexible endoscopy scope down through their nose, into their mouth, and then went down and looked at 11 different structures internally. You saw a picture of that earlier. And some of the spaces to get an idea of whether they were swelling internally or not. And then we used the CTCA criteria for fibrosis, again, to help us standardize documentation of the physical examination findings that we had. We did a symptom survey that was developed at Vanderbilt University. It's the most common symptom survey for head and neck cancer used in the world these days. We looked at a functional index called the Neck Disability Index. This is a 10-item instrument where we look to see if the person had pain, issues with personal care, lifting, just activities of daily living related to what was happening in their head and neck area. And we also evaluated them using something called a Karnofsky Performance Scale. And this is really simply a scale where you rate an individual's function from 0 to 100. 0 means they're not alive anymore. 100 means they have no impairment. So what did we find? Well, for hypothesis A, we thought we would find 20% of head and neck cancer patients had late effect lymphedema or fibrosis. What we found at baseline, this is the first time we measured them prior to having any radiation or having any chemotherapy, okay? 63% had external swelling before they were ever treated. 41% had internal swelling already started, and 42% had some kind of fibrosis finding was positive on that initial physical exam. This literally confused us because there's nothing in the literature that would suggest pre-treatment you would find this in these patients. So we thought, well, maybe we just had a lot of surgical patients that we, saw after surgery, and that's why we're finding that. So we went on and broke this down. And what you're going to see here is that it really didn't make a difference whether they had surgery or not in terms of the internal and external swelling, okay? The only thing that surgery seemed to impact was the fibrosis finding, meaning that we think some of that fibrosis that we found was related to the surgical procedure. But again, this was stunning to us to find this level of swelling internally and externally before we treated the patients with cancer. This tells us in this population that it's something other than the treatment that may be triggering lymphedema and fibrosis in patients who have this disease. We speculate that perhaps there's a huge inflammatory component that is going on because the patients have been diagnosed at late stages and the tumor creates a lot of cytokines that cause inflammation. And we collected cytokines when we did these exams, and we have had some positive findings from that. But remember that theory slide I showed you and told you, only wanted you to remember that we have hypothesized subsequent to treatment, this is what we find? Well, we were really wrong. And this is why you do research, to find out if what you think is right or not. Well, so at the end of the study, at 18 months post-treatment, we found that 92% of everybody in the study had late effect external lymphedema, 93% had internal lymphedema, or 83% had fibrosis at some point in time during our assessments. And most of them still had it at the very last visit where we ever saw them, 18 months post-treatment. And we had to rethink how we were going to analyze the other hypotheses for this study. Because to look at differences in patterns and differences in symptoms related to lymphedema and fibrosis, we had to have some patients who didn't have it to compare to, and we simply didn't have enough of those patients to do the kind of analysis we planned. So we just had to meet with our statistician and think about how we wanted to analyze this data. So what we did very simply was decide that we would look to see if there were different trajectories of this disease process, different trajectories of how people developed and sustained external lymphedema, internal lymphedema, and fibrosis over time, trying to see if there might be groups of patients that were more severely impacted over time than others. So that's what we did, and I'll spare you reading how we set up the statistics, but we did decide to look at trajectory modeling. So here's what we found for the characteristic patterns of late effect fibrosis and lymphedema for the second hypothesis. We found two trajectories for both internal, external, and fibrosis presentations. One group had very low, if any, incidence of moderate to severe lymphedema or fibrosis or internal swelling. But a second and larger group, meaning more of the patients in the study, fell into the trajectory of moderate to severe fibrosis and lymphedema. And here you'll see the specific numbers for that. But basically what you can see is the majority of the patients fell into a more severe trajectory for each of these three categories that we were looking at: internal and external lymphedema and the fibrosis. And I want to give you an idea of what this looks like very quickly. This is a gentleman at baseline who came to us with positive swelling. You'll see here, this is his tumor. But if you look at his ear, if you look at the side of his face, we took pictures on physical exam, he already had substantial swelling in this area, and this earlobe was about twice as thick as the other earlobe. We have learned to appreciate earlobes in these patients. It's one of the first places the swelling develops. This is what the same patient looked like at the end of the 18 months. He actually looks better. But unfortunately, he was left with grade 1 fibrosis, and he was left with 3 of those structures we look at internally with that scope being permanently swollen. So this left him with some swallowing issues. This is one of the more severe trajectory patients, and I assume you can tell lots of swelling here. This patient was 42 weeks post-treatment when we took these pictures. But he came in swollen also. But this is what he looked like 42 weeks after treatment. He had had lymphedema therapy, by the way. We didn't just identify this and not refer them. We referred them for treatment. But this is post-therapy. Heaven only knows what he would look like had we not sent him to therapy. This is to give you some idea of the severe trajectory for internal swelling in patients who haven't had surgery. Here, you can see there's a wide kind of space there where your food might can go down. Here, you'll see that's gone. Okay, this is the same patient. Here, not so bad. Here, you can see lots more boginess. So you really can look down these throats and see big differences in the patients. It's not hard to imagine why swallowing is hard if that's the only patient that have to swallow through. This is an example of fibrosis, and it doesn't photograph very well, but what we tend to find on physical exam with the fibrosis patients is they tend to start having demarcations in their skin, and they get tight, almost contracture-like feels when you can feel cording in their necks. And so you have to really do an examination to see how this is going. But it doesn't photograph as well as it feels. And we have done, as part of the study, grayscale ultrasound and ultrasound elastography, and have found that we can pick up some of this fibrosis using those techniques. But this is just this woman, as you can see, how she continues even over time, just look kind of pinched and pulled in her neck. So for the last hypothesis for the aim, we wanted to look at patterns of symptoms. And again, we had no comparison group, so we looked at symptom trajectories. And here's what we learned. That there are again two trajectories in symptoms, which makes sense. The symptoms align with the severity of the lymphedema that we had found in the other two trajectories. And in all cases, for every symptom that we looked at, the moderate to severe trajectory patients, people who had the most severe swelling and fibrosis, had more problems on the symptom surveys that we did regarding swallowing, nutrition and weight management, mucus production in their mouth, dry mouth, voice problems, inability to open their jaws. Again, in every case, if you had that severe trajectory, you had this more severe symptom profile. The performance status, that Karnofsky score, also was reflective of being much poorer in patients who had the more severe trajectories. But the Neck Disability Index really didn't tell us much. We had no findings one way or the other. And we think that's probably not a really good tool to use in this population. But we had no results one way or the other for that. It really didn't change over time. And that's why we don't think it's a very good instrument. It's impossible to imagine that nothing changed over time in that instrument when it changed over time in everything else we looked at. For the internal swelling, what did we find? Those with the most severe internal swelling had multiple symptoms that were associated with that internal swelling. And some of the interesting ones here, if you look at the bottom, their teeth hurt, okay? And they had general pain, not just in the areas where but they just hurt all over when we would talk to them. And then some of the similar things you found with the external regarding swallowing, mucus, dry mouth. And again, you would think that these are radiation symptoms. These are long post-treatment when we looked at these. And again, the Karnofsky performance scale did show that performance function got worse, but the neck one didn't show us much of anything. For fibrosis, which is that contracture component I was talking about in the stiff skin, it actually had fewer symptomatic effects for the patient than the swelling did. But when they had effects from it, it was profound inability to open and move their jaw and profound inability to move their neck. So if they had that stage, that trajectory for the most severe fibrosis, this was about as much as their mouth moved, and this was about as much as their head would turn. So it's very profound. Clearly need for intensive physiotherapy for those patients. And then no relationship for performance overall or for the Neck Disability Index related to the fibrosis. So what did we learn from this study? Internal and external lymphedema and fibrosis is present in many head and neck cancer patients before treatment. So that continuum that we proposed starts before we do anything to them. We also learned, and I'm going to show you the graph here, that 6 to 12 weeks post-treatment is when we start to see these longer, more permanent changes come into play. So if you're treating someone who's had head and neck cancer treatment and they're in your clinics for lymphedema or physical therapy treatment, no, 6 to 12 weeks post-treatment is when you may begin to see some of these changes become more pronounced. We are not sure the mechanism for this. We don't know what's causing it. I gave you my best guess early in the presentation. but there's some kind of interaction between the host, which is the patient, and their body, the tumor, and other things that we may not know. There's probably a combination of many factors happening, but this looks to be that lymphedema in head and neck cancer patients is a little different animal than some of the other parts of the body based on current science. In summary, 2 trajectories for each of the 3 areas that I addressed. Trajectory 2 has serious symptom profiles, swallowing, movement, pain, dentition. I will tell you that some of the severe trajectory patients, the external and internal swelling, when it was combined, ended up having had a tracheotomy. And I do have data about the impact of combined, but that's too much to go into today. But let me just say, if you're swollen inside in those structures and externally, you're at high risk for need of emergent care if you are not seen by a therapist very quickly. This appears to be chronic. Unfortunately, we did not see at the end of 18 months these problems resolving. So it looks like this is perhaps a lifestyle change that the patients are going to have to cope with the rest of their life. We also can attest to the fact that unlike lymphedema in limbs that may move through these grades over years before it goes from stage 1 to stage 2 to stage 3, in these patients it was a matter of weeks to months when we saw these changes happen. When and how to intervene with this is the big question that our research team is considering now. Clearly, we have to look at a lot of data that we have and determine if there's anything pre-treatment that we might be able to do, and then how to carry through post. As with any good study, I guess we've raised more questions than we've answered. But what I'd like to leave you with today is just for the therapists in the room, just a thought that this is much more prevalent than is known. And while I only presented physical examination findings today, we also have the ultrasound, CT scans, and some other diagnostic tools that actually align perfectly with these physical examinations. The take-home message for that is, if you can see it and feel it, it's there. And don't ignore what you as a clinician are finding when you do the exams for your patients, because these other more extensive tests will back up what you're finding. Thank you.
Thank you. That's I guess head and neck cancer is almost a poor cousin of lymphedema research, and that research is must have been very elegant. And I guess one question I have as a radiation doctor, surprisingly high rates before surgery radiotherapy.
Yes.
That's an amazing.
Yeah, and the part that's interesting is we did look at radiation dose to see if that had any negative findings totally, which in some ways isn't surprising with the fact that we found it before we ever gave them any.
And I guess the one thing you see in breast cancer is pectoral fibrosis from radiation. And did you correlate combined chemo radiotherapy with fibrosis of cervical fibrosis?
We are doing that data analysis right now. This is literally very recent, but we are looking at that as we speak. Mary's probably working on it this week, actually.
Does anybody here treat head and neck lymphedema? Yeah, quite a few. Question at the back.
Yeah, very interesting thought. Can I just ask you quickly, arm and leg lymphedema, when chronic, can lead to the deposition of adipose tissue, fat in the limb. Do you ever see fat deposition in chronic head and neck lymphedema?
Not within the 18-month time period. They tend to get more cachexic looking, actually. Less adipose tissue and more of a swelling and stuff underlying a basic cachexic appearance.
And related to that, my next question was just, do you see a difference in the fibrosis or not as to whether the patients have HPV positive tumours or negative?
We did look to see if the viral status of the tumor had any impact on the outcomes. I didn't present it today, but our findings are totally negative. The type of tumor does not seem to be influencing this.
And since you mentioned cachexia, can I ask you one last question? You said you mentioned cytokines, and if you're not ready to comment on that, no problem. But does TNF go up, tumour necrosis factor?
That was one of our positive findings for this, and it was elevated at baseline in many of these patients, as were some other cytokines. I have the data run for that, but for time limitations, I was very selective. But yes, that is one of the positive cytokines. But there are more than that.
I might just get a comment from Dr. Klein, who is a plastic surgeon working with the lymph node transfer space. Also, in your head, Nick,
Sheila, thanks for the research. It's really interesting, and because I have a lot of interest in head and neck surgery as well as lymphedema. One question I have is that often we don't see lymphedema as a problem in head and neck because it's in a, I guess, anti-gravity position, and also it's not an area that's so functional in terms of the arms, the legs, where you use day in, day out, where tongue moves, you talk, but often patients seem to get by, so it's often ignored. And your research raised a lot of questions, but my thoughts are, one is the pre-operative or pre-treatment lymphedema, was it related in any way to either the subside of the tumour? So, if the tumour is laryngeal tumour or tongue tumour or tongue-based tumour, it will block in fact drainage through the back of the tongue, through tongue veins. And secondly, the amount of tumour burden in the neck. So someone who's got N2 and 3 stage disease, are they more likely to get lymphedema than someone who's at N0?
I will tell you what we found with our data analysis. Location was, we had totally negative findings for that. We had, in terms of the, tell me that second question again. I want to make sure I understood what you said correctly.
Just the size of the tumour and the neck disease.
We have not run size of tumor. We did run stage of disease and had negative findings with that also. But I will tell you, we didn't have a lot of early stage. So if you had a lot of early stage, you might find that difference. We didn't have it. To get to, and I'm going to be very quick, we had an ENT person, a surgeon, and a radiation oncologist as part of my team. When we first started doing these internal scopes, the ENT doc who did most of them for us said, I'll do them and I'll record it on that form, but I've been doing this for 25 years and have never seen this. He did 4 and called me up and said, I've been seeing this for 24 years and not paying attention because I was looking for cancer. I wasn't looking for this. And this is now standard. We evaluate all our patients for this at the university now for the internal spine. And the surgeon and radiation doctor actually came to the same conclusion. They had not realized what they were seeing. And, but again, my biggest concern about presenting this is people would think we had inflated these statistics, but we have reams of data from other testing to support these physical exam findings. It all converges when we look at the data, regardless of how we looked at the problem. So, lots to do.
Thank you. Great research, and thank you for the presentation.